Today, we're going to be taking a look at value creation in behavioral health. This is a particular element related to private equity investing, but also strategic buyers. And as we start to build the market, more institutional investors looking at and understanding value creation within the space. It's something that surprisingly a lot of the initial forays into the behavioral health space has gotten wrong. So we can look at the massive investments in telehealth during COVID within behavioral health, but also we look across the space in terms of substance use treatment, in terms of autism, in terms of just general behavioral health and mental health services. And whether we're talking about large plays buying up a lot of counseling officers and group therapy practices, or if we're talking about more of our high-end residential facilities and higher levels of care, or psych hospital plays, there have been a significant number of failures in the space, and there are probably more dead bodies in terms of unsuccessful ventures than there are successful ventures within behavioral health. Why is this? One of the primary reasons from my perspective is that the thesis is often wrong within behavioral health. So part of what I'm going to be talking about today is the different elements of the untenable theses that I've personally seen within behavioral health and why they haven't worked or aren't working. And then obviously we'll take a look at what does work in this space and what is a more viable or workable thesis. So when we look across the space, we have seen some successful exits here or there, but the majority of those have been right time, right place dynamics. The market was hot or the market was frothy and someone just happened to get in on the right time. There wasn't necessarily a lot of value creation that happened. And of course, we've had the low cost capital environment for the past 15 years. So it was much harder to make mistakes. It was a lot easier to just basically buy an organization that was hopefully growing and sell it for a higher valuation down the line. That's no longer the case today. Our cost of capital is much higher with the interest rate increases that have normalized versus the past. And so that's caused a refocus on value creation. And then also the related successful exits have been more mom and pops or your lower to mid-market PE shops that have sold to Acadia or sold to UHS or sold to a slightly larger firm, often without experience within behavioral health or healthcare. We've seen a number of tech-focused PE firms come in and start to make forays into behavioral health. None of those have gone well. So what is it that's working? What is it that's not working? I just want to share my personal insights today. So who am I? Why am I talking about this? So I own probably one of the largest marketing firms in the country for behavioral health. And then we also have a very sizable consulting wing that works specifically with private equity backed organizations within behavioral health, as well as just strategic growth organizations that maybe don't have sponsorship, often at the enterprise level. So we do work with lower and mid-market firms as well. We will do work with startups, but the vast majority of our clientele are more enterprise level. So among our clients count UHS, American Addiction Centers, Recovery Centers of America, Clean Slate, Community Medical Services. So these much larger organizations that are trying to operate nationally at scale. And then on the private equity side, we work with Regal Healthcare, Vistria, Summit Capital Partners, Deerfield, Webster. So a lot of these organizations that have tried to make bigger plays within behavioral health. We even do specific consulting work for KKR. So they've contracted with us to help them really understand the behavioral health market and make some of their initial forays into the space, just because we have over $3 billion of operational data from a national level across levels of care, across service level types, something that McKinsey or Bain Capital is just not going to have the unique market insights on. So we've been very fortunate to be able to amass large data sets, but then also build a lot of boots on the ground experience with organizations that are trying to grow and scale and be successful in this space or not. We've learned just as much from the failures as we have from the successes. We do a lot of work, especially on the consulting end, related to turnarounds, related to due diligence for potential new acquisitions, as well as related to exit strategy. Oftentimes we're getting called in when the current sponsorship or the current executive team doesn't quite know where to go next, and we will help them build that roadmap and then execute on that roadmap. So I'm going to share with you today what elements of the value creation theses that a lot of private equity firms have gone into the behavioral health space with that have not held up so well, and then talk through the more successful models and the opportunities that really do exist within this space. So the first untenable thesis, this is really the main one that I see, whether I'm looking at a pitch deck for a private equity firm that's looking to get into the space, or I'm looking at an actual existing behavioral health provider that is trying to access more capital or maybe sell to a private equity sponsor. In these situations, it's often the case that the claim will be made that there is all this demand within behavioral health and that there's a large unmet need. So this is what I call the field of dreams thesis. If you build it, they will come. You will automatically grow and be successful because all you need to do is open up shop and the patients will flood in. This is not the case, and there's two reasons that this is a non-viable or an untenable thesis. First off, there are saturated markets. So 15 years ago, or really as parity came into play from the mental health side of things, when we had the Affordable Care Act and Obamacare, suddenly mental health was covered where it wasn't before. This really started the initial explosion into substance use treatment and behavioral health services because they were finally covered by insurance. Now, back then, there was an opportunity to simply enter the market and you could fill up just due to the fact that there was more demand than there was supply. That's absolutely not the case as we sit here today in 2025, and that hasn't been the case for at least 5 years. There is so much investment in this space, and there are so many providers in every single market across the country that you do not see additional opportunity in terms of a field of dreams thesis. There is a little bit of opportunity if we look at rural markets, but obviously there's not a lot of high volume there. And then there is significant opportunity within the Medicaid space, but obviously for various reasons, people tend to find Medicaid less attractive than commercial insurance, out of network, or private pay models. So I just want to take a quick look as an example of what's going on in this space in terms of saturated markets. So let's take a look at, for example, Indianapolis addiction treatment. Let's see what pops up. So if we scroll down, we can start to see all the providers here, and we look at this. And so Google Maps on average will show somewhere between 15 and 20 providers in a given screen view. And so we can see there's tons of them, and they're all within driving distance. If you're familiar with the Indianapolis area, basically this is a 15 to 30 minute drive from anywhere in that central location of the map. And then as we scroll in or zoom in, we'll see that there's more and more providers. So again, Google tends to only show 15 to 20 in a given screen. So as we zoom in, we'll suddenly have more pop up and more pop up. And this goes for every market in the country. So let's just type in Nashville, see what we get. And we can see here the same thing. So there's just providers everywhere. Let's do Atlanta depression counseling services. Scroll on down. Okay, so Atlanta depression counseling. So we can scroll here, same thing. As we start to move things around the map, we can find that there are just tons and tons of providers everywhere we go. And you'll also notice here that part of what's happening is they generally will try to focus on Atlanta because we typed in Atlanta depression counseling. So it's not even showing some of the suburbs, for example, but there are just probably over 100 providers that provide counseling services within the Atlanta area. Let's do one more. Why don't we do teen treatment, Columbus. Let's do Chicago, Illinois. Chicago. So our volume with teen is significantly less. There are just a lot less teens that go to treatment than adults for various symptoms or disorders. But we can still see here that even within driving distance, there are a significant number of providers. And so what does this mean as a potential private equity firm that's looking to make investments in this space? It means that there is not a field of dreams opportunity. There is no supply-demand imbalance. Really, you're fighting tooth and nail. You're trying to steal market share away from the incumbents or the existing competition. So markets are extremely saturated across behavioral health, across service lines, across levels of care. Again, the only real opportunity is rural areas, and then there is some solid opportunity for some specific service lines within the Medicaid space. Psych hospitals, no, those are actually incredibly competitive across the country. Those are saturated in most major urban markets or metropolitan markets. MAT providers are oversaturated, even in small rural communities these days. So your only real opportunity on the Medicaid side is more outpatient counseling or some higher levels of care within the SUD or mental health space. And then the other reason that this thesis doesn't work is because most diagnosed patients don't actually seek treatment. So a lot of investment firms or actually even strategic buyers thought for a long time that there was all these patients that needed treatment and then just weren't able to access it. It was an access issue. If we open up more facilities, then clearly we will have people coming in and banging down our door for treatment. And that's not the case. And the reason for that is that most people who have a diagnosis or could be diagnosed with various mental health disorders do not seek treatment. So if we take substance use as an example, SAMHSA, the Substance Abuse Mental Health Association arm of the government, does national surveys every year called the NASARC survey, and they will directly ask people, you have the symptoms or you qualify for this disorder, are you seeking treatment? And for substance use, you will see that around anywhere from 2 to 5% in a given year actually seek out treatment for services. 2 to 5%. That's a really small number of people that are actually paying for treatment. If we look at mental health counseling, if you look at things like depression or anxiety, it's about 8%. So there's just not a lot of people. And also remember that behavioral health is hyper-local. That's something that I'll talk about throughout this presentation. People aren't going to travel for the vast majority of services. Obviously, most behavioral health services are during the day. Maybe you see a counselor once a week for an hour. Maybe you have a more intensive level of care where you're going to treatment for 3 to 5 hours, but you're still going home at night. And so that means that you do not want to be traveling, an hour one way and an hour back. You want to be going somewhere within a 10 to a 30-minute drive to ensure that you're not wasting a lot of time on the road. Probably already aren't super excited about treatment, much less driving all that time. So the vast majority of providers, especially on the outpatient side, pull from a 10 to a 30-minute drive radius in their particular markets, which further limits the number of patients that they have access to. Most metropolitan areas, if we look at a 10 to a 20-mile radius, which is where a lot of patients are coming from, you have maybe a population of about 100,000 people, maybe up to 250,000 people in more dense urban areas like in LA or New York. However, if we look at 100,000 people, let's say that is an average for most of the US, right? For any kind of small radius that we're looking at. What percentage of people struggle with substance use? It's about 10% of the US. So 10,000 people in that radius. What percentage of people struggle with depression or anxiety? It's about 20%. So then we've got maybe 20,000 people in that radius. But now again, we've got this issue where only 8% of people seek care for depression or anxiety in a given year, even if they have a diagnosis. So now we've got roughly 10% of 20,000 is 2,000. So we only get 2,000 people per year seeking treatment. Now, most providers are only accepting commercial insurance. And so now we have to cut that in half. And so now we've only got 1,000 people that are potentially seeking care in a given year for this small radius in which we're going to be pulling patients in from. And that's just for us trying to fill our particular program, not counting those plethora of other providers that we're competing with in the marketplace. So at the end of the day, for behavioral health, there is a pretty small, limited number of available patients in a given geographic area and a large number of providers. And so for this reason, this idea that there's a supply-demand imbalance is absolutely wrong. It's not viable as a thesis, and so we can't operate off of that. Another untenable thesis, number 2, that I often see when I'm talking to private equity firms or we're sitting having an executive meeting, is the economy of scale idea. So this is why you'll see a lot of private equity firms make massive investments, and they'll take a platform company and then try and copy and paste it and open a bunch of other locations, often in a geographically widely dispersed area across the country, which is something we strongly recommend against. I'll talk more about that later. But the idea here is that we can get an economy of scale. If we've got a number of locations, then somehow we're going to be able to reduce our overall costs through some kind of back office economy of scale cost savings. And that's just not the case with behavioral health. So behavioral health is a service-oriented business. That means that depending on your model, somewhere between 40 and 60% of your overall revenue is going towards direct labor cost related to clinical care or supporting the admin around that clinical care. On average, you'll see like 50% is a pretty standard norm. It varies with different providers, but so 50%. So as we have more patients come into the program, we need more staff to care for them. We need more nurses, we need more therapists, we need more support staff. And so there's no economies of scale from a labor cost standpoint there. If we look at other markets and verticals, we'll often see an economy of scale around finance or around marketing costs, but that doesn't scale for behavioral health either. If we need more patients, we have to pay more for marketing. I'll often see large organizations make the very serious mistake of trying to centralize their marketing and then somehow lowering costs because of that. Let's say that our patient acquisition cost is $1,000 for a higher level of care, which would be pretty average for a lot of high levels of care in behavioral health. That $1,000 is your floor for marketing. So if I have one location and we need 30 patients, I'm spending $30,000 a month as a marketing cost. If I have 2 locations where I'm filling up those programs with 60 patients, $60,000 a month is my marketing cost. So as we open up more availability or expand our capacity, we have to then expand our marketing cost. There is no scenario where we are getting a cheaper marketing cost by centralizing the marketing with a head office or with a specific vendor. Each location really requires its own P&L. And so every location, every facility we have needs its own P&L, needs its own marketing budget that has that floor. And whatever our cost per admission is for that level of care and that service line, that is not going to give us a cost savings as we scale. So there's no economy of scale there. RCM is the other area, billing. We need to get reimbursed for obviously the care that we're providing. And as we submit those claims, the more patients we're seeing, the more claims we're submitting. And so there's no economy of scale there because the more we grow, the more billing we have to do and the more we have to pay. Now, most organizations will outsource their billing, and your average billing company will charge somewhere from 3 to 6% of realized claims. That's really cost effective. So if we have $1 million in reimbursables that are coming in, then we are only paying somewhere between $30,000 to $60,000 to our billing company. That's not even one FTE. So again, a mistake that some larger organizations will make is they will try to bring their billing in-house and they'll try to centralize that, assuming that there's some kind of magical cost savings there. Because as you get up to larger and larger amounts of billing, then obviously that 3 to 6% that you're paying looks pretty significant. But at the end of the day, it's not, because it's highly, highly scalable. Again, if I'm doing $1 million in realized claims, then I'm paying my billing company $30,000 to $60,000. If I'm doing $10 million, well, now I'm paying 300 to 600,000. But still, again, we think about from that unit economic perspective of each of these locations and service lines has their own P&L, and we need more staff to process more claims. That's why the billing company is charging you more. You can't provide more cost-effective services centralized internally for $1 million in reimbursed claims. As you add on $1 million in revenue, $1 million in revenue, you have to up your staffing models to account for those additional claims. And there's no point at which you're going to have a higher cost savings than the outsourced billing company. So in those situations, there's just literally no back office, cost-effective economy of scale within behavioral health because it is so hands-on, service-focused. Obviously, you have your standard overhead, you have your real estate, no economies of scale for those either. As we need to grow and expand and serve more people, we need more space, we need more things. Another issue that we have with behavioral health is there's no national brand clout. So one place where you get economies of scale is eventually you reach a point where you have a certain level of reputation within a community or region, nationally if you're a really large company, and that brings down your customer acquisition costs. It brings down your CAC. As you're more recognized, you benefit more from mind share, from referrals, from word of mouth, these things that have a lower marketing cost. You can then gain more patients. If we want to think of the Mayo Clinic, for example, from a cancer treatment perspective, they do a lot of marketing, but if you talk about cancer treatment, that's most people's go-to of the hospital or the care provider they would want to work with. So their marketing costs are lower to get a cancer treatment or cancer patient in because they're so well known in the space. If we think of addiction treatment, who comes to mind when you think of top addiction treatment provider in the country? You may think of Hazelton Betty Ford. Unless you're familiar with the addiction treatment space, that is probably the only potential name that comes to mind. But Hazelton Betty Ford does not have locations across the country, and most people do not want to travel for treatment. Behavioral health is largely hyperlocal. So there's no significant advantage to Hazelton Betty Ford having a reputation because most people are not going to fly to the program nationally. Now they do get some benefit out of that, right? But it's not significant to the point where they would benefit like a Nike or a McDonald's or a Starbucks does from having a really national reputation. And this is normal within healthcare. If I ask you who your go-to cardiologist is, or who's your go-to physical therapist, or which clinic do you go to for MRI scans, you don't have a brand in mind, an organization in mind, like you do for coffee or for fast food or for easily assemblable furniture that's cheap and good for a new apartment, right? I mean, we all have organizations that come to mind when I give those examples. We don't have organizations that come to mind when I talk about your favorite mental health provider, for example. So the national brand clout is not a really viable play. It doesn't provide us the economies of scale that we can get in certain other markets. That was kind of the thesis with telehealth. There was this idea that your Talkspaces, your BetterHelps, your Lemonades, all these different telehealth providers would somehow be able to have a national reputation, which would then eventually lower their customer acquisition costs. But we have not seen that be the case. Obviously, BetterHelp, as of last year, is still not profitable. Cerebral has many legal issues, but in addition to that, it's not been able to be profitable. Talkspace has not been able to be profitable. All of these telehealth providers that came out during COVID have not been profitable. And then also, I can speak very clearly just from the work that we do across the space, most of our clients have some kind of telehealth offering, and that telehealth offering is not a significant leader of value. Most of the time, it's actually a loss leader. So we don't have a national reputation. We can build a local reputation, and that's significant, and that's something we'll talk about when we talk about what a successful thesis looks like. But because behavioral health is hyperlocal, that doesn't allow us to get these economies of scale that we might get with other verticals, or that you as a private equity firm might be used to from some of the other verticals you've invested in with your portfolio companies. Being hyper local, we can't expand our brand to a new geographic location. So let's think about, we're a provider and we're in Nashville, Tennessee, and we decide to open up a new location in New York or LA. Who knows us in New York? Who knows us in LA? Nobody. Nobody knows us in the location. So we have absolutely no brand or reputational benefit from a marketing standpoint because we're based in Nashville, Tennessee. And that makes it difficult to get any kind of economy of scale from the marketing standpoint, because all economies of scale in marketing are all about brand and reputation, driven by word of mouth and community mind share that you can't build up when you're geographically dispersed. We see this as a significant mistake a lot of our private equity clients have made in the past. It's often one of the reasons that we get called in. They bought a provider in Denver, Colorado, and that provider has been in the community for 8 years. They're very established. They have great referral relationships. Everyone knows who they are. And so they take a copy paste and they say, okay, we're going to take your systems, your processes, your model, and we're going to transplant it over here into Atlanta, Georgia, or we're going to transplant it over here to Milwaukee, Wisconsin. And then what happens is they struggle and are not able to make that new location profitable because there's no benefit. Yes, you were able to get it up and running quicker because there was the systems and processes and kind of platform model in place that you could copy paste, but that's not what makes a program successful. What makes a program successful is its reputation, its referral partners, its community mind share, and moving to a brand new state so far away, there is none of those advantages that carry over or cross-pollinate. That's a significant problem. And so the providers end up struggling and failing because they didn't realize how difficult it was. The original organization that they acquired had 8 years to do that really difficult work of building a reputation in a community, of building partnerships. Now we don't have that. Not only is there a difficulty in building a reputation from scratch when nobody knows who you are, but again, if we look back at the beginning of this presentation, we saw how saturated and oversaturated basically every single metropolitan market in the country is, and as well as most suburban and smaller markets. So you're not just trying to build a reputation, you actually have to steal market share from entrenched competitors. How do you do that? So if we take the example of the established provider in Denver that we originally bought, they have all these relationships, they have all this trust, people know them, they're comfortable referring to them. Imagine a competitor coming into that market and then trying to steal patients away and build those referral relationships and build referrals. People aren't going to be willing to do that because they already have a trusted provider, someone they've known for years, someone they've referred to for years. They're comfortable with that organization. Why in the world would they start providing referrals to a brand new organization that they never heard of? And the same thing happens from a direct-to-consumer standpoint. If I'm looking online and I see a couple providers and maybe I don't know where to go. I'm like, well, I don't know where to go for counseling services. I don't know where to go for drug rehab. I look online and I see 3 examples pop up on Google Ads right at the top. Well, one of the names I recognize. I've heard it a couple times. I've been living in this community for 30 years and I've heard the name of this provider. I've heard it casually from friends. I've seen a commercial or 2. And then I've got 2 other ads of organizations I've never heard of. Which one is that person going to click on? They're going to click on the organization they've heard of before. There's at least some kind of modicum of trust that's been built up. More than that, if that provider does a good job, they've got good online reviews. So when the individual clicks on that provider, they can see that they've got 50 5-star reviews. And then when we look at the new provider who they've never heard of before, there's no reviews or there's 2 reviews on there. That doesn't engender the same kind of trust. So that creates significant difficulty because now you're battling uphill, trying to not just build a reputation, but steal volume in terms of referrals and community mindshare away from established incumbents. That's very, very difficult to do. And you can do it. We'll talk a little bit about how you can, but it's not easy. And I can tell you for a fact that a lot of the private equity firms that we've worked with have been quite surprised when they took their copy-paste model, tried to open a new location far away, and then struggled and just constantly could not get it off the ground. That's because you're working uphill. Now, there's a whole roll-up thesis, right, related to all of this, is if we go in and we open up countries, de novo builds across the country, or we acquire across the country, that we're going to get some kind of size multiplier, right? We went from 3 facilities and now we've got 15. Or we expanded it to 50 facilities across the country, and we're hoping that we can now package all those together and sell it for a significantly higher price, right? That's often the play that a lot of the roll-ups try to get. And it's worked in other verticals, but it only works if there's integration across the providers and if there's actual clear value creation in terms of how all of these different locations are working together to add value. What we've seen in behavioral health is more of a hodgepodge. Good example would be Webster Capital taking Baymark to market in 2019. They had purchased a large number of MAT providers across the country, tried to package them together, and then sell it to the market at $1 billion valuation. No one was biting, no buyers. Why? Because once we get to that dollar amount, we're starting to talk about more institutional investment or much more sophisticated, larger upmarket PE shops. And those PE shops are looking for something that is a real platform that's integrated. And that's not what Baymark was at that time. Baymark at that time was a bunch of mom and pops that had been pieced together. And so you didn't have consistent EMRs, you didn't have consistent systems and processes, the care models were different at all the different providers. UHS and Acadia have struggled with the same thing. If you look at UHS and Acadia, it's a lot of mom and pops. Most patients wouldn't even know that they're in a UHS or an Acadia facility. There is no real recognition of what's different about UHS or Acadia or any kind of integrated model. Acadia just started actually providing or using an EMR within the past couple of years. UHS is still working at integrating an actual electronic medical records into all of their locations across the country. They're still using paper for most of these organizations, right? That is not an attractive acquisition for the vast majority of sophisticated institutional investors. So the roll-ups at the end of the day end up just creating more headaches. You've got different cultures, you've got different systems and processes, there's no integration, you've got different licensing requirements across states, you have different insurance negotiations and contracts across states, completely different environments that you're working in. That national expansion leads to a significant headache that most buyers at a much higher upper market, sophisticated level just don't want to deal with. They're expecting that to be taken care of before they're willing to purchase or invest in those organizations. So roll up, not a good strategy overall. And I've covered telehealth a bit already. This is something that I could spend a whole presentation on. We do have articles on our website that go into the value creation component of telehealth. For the most part, not overly viable. You have all the same challenges you do with brick and mortar facilities. As you scale, you need more counselors to provide access and care to more patients. You need more back-end billing. You need more marketing. And where telehealth has really struggled is still most patients really don't prefer telehealth programming. There is, on the outpatient counseling, the once a week counseling side of things, there is a certain number of patients that are more interested in telehealth counseling than going to a brick and mortar. But for all other higher levels of care, that's absolutely not the case. And then even for the lower levels of care, there's still a strong preference for brick and mortar for a sizable portion, which means that your customer acquisition costs are become very important in your cost model. And for most brick and mortar, for running digital marketing campaigns at a national scale, like your Talkspaces, your BetterHelps, your Cerebrals, you're talking about a $400 to $600 CAC. Well, that's not viable, right? Because you're not even making that much on a patient until they've been with you for 3 or 4 months. And the average retention rate for most patients is only about 3 months. In fact, the mean number of sessions that the average patient attends is 1. So you have a high volume of patients that never come back after the first session. A lot of patients after that don't stay for longer than 3 months. So it's very, very hard to recoup your marketing costs from large national marketing budgets. That's why hyperlocal tends to work better, because eventually you have this cumulative advantage of being known in the community, being the go-to provider, building up referrals. And by staying small, you don't need that much volume. So bottom line is telehealth doesn't have the economies of scale either. Now, another untenable thesis is often the clout with payers. This is a copycat model from healthcare systems and hospitals. PE has definitely gotten into the hospital game over the past decade, and we've found opportunities in those situations where, because we're serving so many covered lives for particularly large payers that operate within that state, we then have clout to negotiate with that payer. If we buy up a couple of the hospital systems and we're the main game in town, now we can take that clout, bring it to a payer, and negotiate higher rates for things. That doesn't work in behavioral health. It can. We have had a couple of clients that be successful with it in hyper-localized markets, but the vast majority of providers have not been able to bring that clout to the table. And there's a couple of reasons for that. Behavioral health volume overall is small. From the payer standpoint, their main cost is physical healthcare services. Roughly 99% of their cost is coming from physical care. It's diabetes, it's obesity, it's cardiac issues, it's cancer treatments. And these are the really high cost, high dollar services that are super expensive for payers to handle. Even if we look at a residential level of care, which is a very small number of patients every year for a particular payer, maybe they're paying $30,000 for that person to go to 30 days of treatment. That's a drop in the bucket compared to cardiac surgery or diabetes care over the lifetime of a patient, or especially cancer treatments. So the small volume means that the payers don't really care that much. It doesn't really affect their bottom line so significantly that there's not a big interest in working with providers on rates. In addition to that, most behavioral health providers aren't seeing that many patients overall in general. So if we look at a residential treatment provider, whether it's mental health or substance use, if you have 100 beds and somehow they're magically all full all the time, there's still only 1,200 patients a year. When you're talking to a payer that has 5 million covered lives in a state, they don't really care about 1,200 patients a year, right? It's not a number that moves the needle for them in any way, shape, or form. So it's not a huge cost to the payer comparatively. And then on top of that, you have a very, very small number of volume of patients that you're serving as a behavioral health provider, again, comparatively, that neither of those are situations that end up giving you clout with the payers. Now, also, payers are state-based. Yes, you can form national contracts with the payers. Like LifeStance, for example, has done a lot of work in building national contracts with some of the larger payers across the country. But they're not doing that because they're getting better rates. They're doing that because it's just logistically easier. And it's also why the payers do it. So the payers aren't going to give you a national contract. They're going to give you regionalized contracts. And they'll say, okay, Southern region, Midwest, East, West Coast, whatever, will give you certain rates. And so that makes our paperwork easier. It makes our contracting process easier. It makes your paperwork easier, your contracting process easier. And so there's a win-win just from the labor cost side of things to both parties. But what's not happening is that you're getting higher rates because you've got a national contract. Most providers are doing state-by-state contracts, and those are negotiated at the state level with the payer, and they don't have the clout, as we mentioned already, to negotiate higher rates anyway. Finally, payers are not confident about the value being provided. I have pretty good relationships with the heads of behavioral health at a number of the large payers, and when we have conversations, they tell me very directly that they don't see significant value from a lot of behavioral health organizations. What does that mean from the payer perspective? It's total cost of care. What is the total cost of care? Are they seeing a total cost of care reduction when they're seeing patients go into treatment programs for mental health or SUD? Yes or no? They don't. by and large. And so for that reason, they're not overly motivated to have any kind of additional compensation for a lot of providers. Now, again, we do have clients that have gotten better rates, and it is because they've been able to demonstrably show significantly improved outcomes from a total cost of care standpoint with the payer, and they're larger. So all of our clients that have been able to negotiate higher rates with payers are quite large in a specific state. And that's the key. There's a very concentrated geographic focus where they've been able to expand over the years, where they're seeing a high volume of patients that allows them to come to the table and actually talk about rates. Now, all of those have also shown that total cost of care reduction. So it's those two factors: really large in a focused geographic area, usually in a state, and then there is clear outcomes that the payers can see a total cost reduction. All right, so those are what's not working. Now, what is a viable thesis, or what is a workable thesis within the behavioral health space that we've seen work consistently? Number one is a turnaround, pretty obvious one. If an organization is failing, or if it's just stagnant, if it's stuck, potentially you have the operational expertise in the space to come in, identify what's not working, and then add value by fixing and improving those underperforming areas. Really common, much easier said than done. A lot of private equity firms don't really have the stomach to pull someone out of bankruptcy or to deal with the turnarounds. It's a pain. Obviously, we'd much prefer just to buy an organization that is growing and successful and trying to make it grow a little bit faster and be a little bit more successful. That's a lot easier than trying to take an organization that's failing. Because if that organization is failing, there's 100 things that could be wrong. Clearly, the team isn't currently capable of managing the turnaround, or they would have done it already. So now we're talking about training up an existing team or firing and hiring a brand new team, which can be a bit of a crapshoot. So lots of challenges to the turnaround model. The current team's lacking, so they can't do it. So we know that we have to come in and add value. A lot of private equity comes in and we have our standard board meetings. We have the calls with the executive team. We're asking questions, probing questions. We're making suggestions and recommendations. That's not going to fly for a turnaround. Again, if the current team could just use a little bit of nudging and then suddenly fix the organization, they would have certainly done that or figured that out by now. They need someone that's going to be much more hands-on. And so that's either the current private equity partners, or ideally you're bringing operating partners to the table. And those operating partners, again, are not just asking probing questions and providing guidance and coaching. Those operating partners are going to be actively involved in the day-to-day of managing that organization through the turnaround. And I can speak to this really consistently from my end. We do a lot of consulting around turnarounds. And so what we used to do was just provide the roadmap and the framework, really granular, step by step. Here's your timeline. Here's where to allocate the capital. Here's the actions that you need to take. Here are the big rocks. Here are the small rocks. Here's who needs to have ownership, et cetera, et cetera. 50% of the time, maybe the providers will be able to execute on some of that. But usually they really struggle to implement it at all, half the time. And then even for the 50% that do start to implement some of it, it usually gets sidetracked, or they're only able to partially implement it. Why is this the case? A couple of reasons. So one, already, if they had the skill set to do this, they would have done it already. And so there's clearly a gap there. Partly they're probably overwhelmed. Lots of things are on fire. There is major pressure around capital and costs and runways. And so they're scrambling. They're already working 80 hours a week, and now they've got a 20 to an 80-page report, depending on what section they have ownership of. And they're trying to implement all these things that they may or may not have experience doing. And so that's really challenging. And then they've just got a lot of work in general. And so they're having a hard time grasping everything without additional support or additional resources besides the roadmap. So current team lacking and just providing guidance is generally not going to really drive a turnaround. So another default option that a lot of private equity firms will resort to is firing and hiring. Current executive team doesn't have the strength or the bench strength that we need. We're going to get rid of them, bring someone else in. This is not easy in the behavioral health space. There is a dearth of talent at the executive level in behavioral health. And in particular, there's a dearth of talent in managing turnarounds. Turnarounds are really difficult as it is. Finding someone that can own one and bring an organization out of a turnaround is even harder. So we might say that we can find someone that just runs organizations well, and that person can hopefully come in and identify the areas that aren't working at our organization compared to what was working at their previous role and implement those things. This usually isn't the case. Usually the problems that the turnaround organization has are not exactly comparable to a successful organization. And the way to get things done is often very different in a turnaround than if you have an established organization that is on a successful track. And so you don't see people come in that can be overly successful all the time. If you can even find them, then you have all the challenges of trying to get someone to move, and are they actually going to be the right fit? If you've got someone on the bench that you know that you've worked with in the past that's really successful, that can be a good option. So this person you've vetted, you've validated, they're ready to go, they're willing to work with you, make the move across the country, do whatever it takes, then that can be a good option from a turnaround standpoint. But just going in and firing the team and hoping that you're going to find someone else to fill that gap usually doesn't end up being overly successful. Now, a major reason for all of the struggle here is identifying the issues. Most private equity goes in and they focus on the spreadsheets. They're looking at the P&L, they're looking at the balance sheet, they're trying to understand the numbers and identify areas of opportunity or why the organization isn't working. But if you don't have specific behavioral health expertise and also specific expertise in that service line, then you're often not even able to identify the problems that the organization has, because they're often multifold and they have specific domain expertise related to each of them. I often tell providers, if I'm going to go in and I want to improve a school and we have low math scores, I used to work in education for a decade, I'm not going to bring in an art teacher to do that. The art teacher has no bearing on the math scores, and vice versa. Just because they're both teachers and work in education doesn't mean that one can switch out with the other. The same is true of healthcare. I'm not going to hire a cardiologist to provide orthopedic surgery. I'm not going to hire a pediatrician to perform a cardiac surgery, right? Just because they're both in healthcare and they're both medical professionals doesn't mean that they are interchangeable. So that definitely translates to healthcare. I can't find individuals, whether from the private equity side based on our previous experience or people that we're working with and bringing in, just because they have healthcare experience doesn't mean that they're going to have anything that's super relevant to behavioral health, especially for a turnaround, right? If you've got a successful organization that's growing and you just need a strong executive to come in and manage that, they can probably figure it out as the organization grows. But in a turnaround, you're on a tight timeline, capital's running out, bridges are burning, you need to fix things now. You don't have the time for someone to figure out the space and then try to figure out a solution. It's not going to work. Additionally, even the service lines within behavioral health are very different. Running a psych hospital is completely different from running an MET clinic, is completely different from running an outpatient counseling center. You don't have comparable experience across those service lines. So you need to be able to identify the issues. Do you have the talent that can identify those issues? Do you have talent internally or someone that you can bring in from your bench or from your operating partners that really knows behavioral health and knows your specific service line to make this turnaround work? Now, not only that, we can't have just a general operating partner. Maybe they were a CEO, maybe they were a COO, a CFO. These individuals are not going to have department-specific expertise. So why is the organization struggling? It could be because their clinical model is not very good. And so patients aren't staying in treatment, they're AMAing, they're leaving against medical advice, you're not getting referrals from community partners because the clinical care is considered to not be good. You need someone that understands clinical care. You need someone that understands how to identify what's not working and improve it. What if it's the outreach team, the business development team? Maybe they're not performing. Maybe you're not getting referrals from the community because that team's not good. Well, I need someone that understands outreach and business development. Maybe it's marketing. Maybe your SEO is not good. Maybe your Google Ads campaigns suck. Maybe you're not doing Facebook or TikTok ads and you should be. Do you have someone that has specific expertise on those digital platforms? Call centers is a big reason that there's a struggle with turnarounds. Call team can't convert the leads that they're getting. All of these areas are requiring specific expertise that a generic operating partner is not going to be able to solve. And again, from our experience, it's never the case that there's just one problem that needs to be fixed. There's always multiple problems at an organization that have to be solved. So when I go in and bring people from my team, I'm able to identify areas that need work, and then I bring in the right consulting and contract partners to help with that. Who's going to head up the clinical work? Who's going to head up the marketing work? Inside the marketing, who's doing business development outreach? Who's doing SEO? Who's doing paid media? Who's helping with call centers? Is it a technological integration that we're struggling with? Do we need a tech solution for a really large call center? Or do we need a training solution? Is it a people issue where we haven't trained the team to be effective as they could be? All of these individuals have very specific domain expertise that they're going to need to bring that expertise to the table to make this turnaround work. The only way they're even going to identify the issues is if you have that bench strength and you have that experience. And so you're able to say, okay, here are the 5 to 6 core issues that we need to work on. And then here's the skill sets that I need. Here's how I identify people that are going to be able to solve these problems. So when we're utilizing operating partners, do we have specific people that are able to identify the problems? Because we're not going to see them from the spreadsheet, right? The spreadsheet's not going to show up if it's a clinical care issue, or if it's a business development issue, or if it's an SEO issue or a call center issue, right? The P&L doesn't give us that information. We've got to really have a qualitative understanding of those different functions within that particular level of care, what the benchmarks are, what a good call looks like, what good clinical care looks like, what a good territory strategy is, what good onboarding looks like for the business development team, what good ongoing support and training is for the business development team, right? All of these things we need particular expertise for. So do the operating partners have that expertise? If you've got all these things, or you're able to assemble that team, then great. Turnarounds are a strong model for value creation. But my experience has been a lot of private equity firms do not have the internal capabilities to identify the numerous problems that are occurring, much less have specific talent that's able to solve them. So unless you have that and really a deep understanding of the particular service line in behavioral health that you're looking to acquire, I would recommend avoiding a turnaround. Local expansion is the most workable thesis. It is the most successful by far from the organizations that we work with. You look at an organization that, let's say, public information would be a Granite Recovery. Granite Recovery is one of the most successful organizations that we've seen, especially having a very, very successful exit to Webster Capital. Highly localized, focused, able to really have a lot of synergy between levels of care, a lot of geographic relevance, a lot of focused political connections, a lot of focused marketing, internal referral structures, ability to take a lot of insurances. All of these things work together to make that organization work versus like a national spread where we're trying to put programming everywhere. So how do we have local expansion, right? Levels of care is number one. You want to think about this from a very simple standpoint of call volume. You got your inquiry volume. These inquiries are coming in every day. You're paying a bunch of marketing dollars. You're paying a bunch of money to your business development team to generate referrals. And so you're getting the calls in. But let's say that you are just a residential level of care. So all you do is provide care, whether it's mental health or SUD. It's residential, which again is a small volume of people that need treatment. Meaning most people that are calling in probably don't need your services. So this is a challenge within the behavioral health space. The average person and even referral partners and professionals, don't really have a clear grasp of what level of care might be needed for a particular patient. That's why we do our assessments. That's why we do our biopsychosocials. But most patients don't need that. And so you have all this call volume coming in that you can't accept, that you can't convert because you are one level of care. A really good value added play is to expand your levels of care. So again, let's say we're a residential provider and we've been turning away all of the intensive outpatients, we've been turning away all of the general outpatient calls, and we've been referring those out to other providers. So we're paying all this money for marketing, but we're not even able to convert that call volume because we don't provide those levels of care. So by providing those levels of care, we're maximizing the existing call volume that we already have. So there is a significant value creation there. Then secondarily, we're getting a larger average reimbursement per patient. So now instead of just billing for residential care, we're billing for residential, then we're billing for PHP, then we're billing for IOP, then we're billing for general outpatient. So we've significantly increased the total value that's being driven by a single patient in the care system. That has a significant impact on EBITDA and the bottom line. So this is a really, really smart play for value creation. Also really important, making sure that it is local. Again, we're not opening up facilities. We don't have a residential in Tennessee, in Nashville, and then open up an IOP in Elizabethtown, Kentucky, right? That's not a value add. We need the IOP to be within Nashville, Tennessee as well. Then same thing with payer type. So if you look at a lot of behavioral health organizations, up to 90% of their call volume is Medicaid. Most individuals on Medicaid are really struggling to find treatment. That's why I mentioned that there's an actual field of dreams model potential with Medicaid for some service levels in certain areas of the country. So again, you've got all this call volume coming in. You're already paying for it from a marketing standpoint, and you're not able to convert any of it. So a value added play is to have a Medicaid model. For a lot of providers, that's not going to be within the same facility or the same program because the operating cost structure is different. Medicaid is a lower reimbursement, and so you need to have a lower operating cost to be able to make Medicaid successful. For that reason, we'll usually have separate locations, potentially even separate brand names or organizations to represent our commercially insured services versus our Medicaid services. But again, the whole goal is we've already got the call volume, we've paid for it. How do we maximize conversions and revenue off that call volume? Even if we're only making 5 to 7% margins on the Medicaid, that's still 5 to 7% that we weren't making at all, and we were paying for the call volume anyway. So really strong value add there to expand levels of care and expand the payer types that you are receiving. Same goes for higher levels or private pay levels of care, is what I should say. So your out of network, your private pay patients, some of these patients don't want a generic treatment program. They want something a little bit higher end. They want some white glove services. Maybe they want a private room. Maybe they want some amenities as part of their treatment programming. And whether you're talking about outpatient services, or you're talking about residential levels of care, certain people will pay more. If you're getting a lot of call volume in, there's going to be a couple patients every month that want those higher level of services. So again, if within our care model and our system of care, we've got private pay options, we've got commercial insurance options, we've got Medicaid options. Now we're able to convert everything that comes into our program, which is a significant ability to add value to an organization that before maybe didn't accept all the insurances or didn't offer all of the levels of care. Then finally, the last workable thesis, I would consider this one the middle of the road in terms of the three that we're looking at here. In terms of difficulty, is a differentiated care model. So this often starts with quality. It doesn't have to be quality of clinical care. Obviously, that's a great one, but it could be the quality in terms of the speed in which you're able to admit people into programming or get people connected to care. A lot of people hate waiting. They don't want to wait 48 hours. They don't want to wait 2 weeks to get into a program or to see a therapist. And so maybe it's the speed at which you're able to work with people. Maybe it's the quality of your aftercare programming. So maybe you're providing pretty similar treatment to everyone else related to your competition, but you provide all these aftercare services. You have an app, you provide follow-up calls, you maybe provide some limited group engagement, on an ongoing basis. That can all be a quality differentiator. What's the point here? Again, the point is the market's insanely saturated, as we talked about. There's a limited number of patients. So if we're going to steal market share from someone else, how is that going to happen? We need to be able to go to a community partner like a hospital and say, look, this is what we do significantly better, demonstrably better. This is why you should be referring to us and not to this other organization that you've been referring to for the past 10 years. If you can provide a significant, meaningful difference and demonstrate it, right, whether that's through your ability to talk about how you do it differently, your online reviews and testimonials, your ability to have third-party outcomes data, however you're proving that to your referral sources, that is a significant method of value creation, but it's very difficult, right? So we go back to our challenge that we had with the turnaround model. How do you identify what's really good? So let's take a really common focus within behavioral health right now is trauma. So on almost every single website of almost every single behavioral health provider, they'll all say they do trauma-informed care or have a trauma treatment component to their program these days. So saying you do trauma is meaningless from a competitive advantage standpoint. Everyone provides trauma, just like everyone provides evidence-based care or individualized care, right? Whatever buzzwords you want to use, these are not valuable unless you can actually significantly demonstrate that you are doing things better and so are the right provider to refer to for patients. The only way you can do that is if you really understand it. So what are your let's take trauma. What are your competitors doing for trauma care? How could you do trauma care significantly better? If you can't answer that question, if you don't have expertise around what good trauma care looks like and how to make trauma care better, then that's not an answer. I can't tell you how often we work with not just private equity, but also strategic organizations that tell us like, oh, well, can you just start marketing trauma? Or can you just start marketing a veterans program? Or can you just start marketing an LGBTQ program? That is a terrible idea. Because it's not the buzzword. It's not the buzz. Again, there's no field of dreams here. We're not just opening a veterans program and suddenly veterans are going to come. Everyone has a veterans program. Everyone has an LGBTQ track. Everyone has a faith-based track. There are multiple options in the community. So just by offering it doesn't differentiate us. The differentiation comes from being able to provide better, higher quality care than the competition is doing the same thing. So how do we provide better trauma care? How do we provide better CBT? How do we provide better care for pregnant women? How do we provide better care for LGBTQ or veterans or individuals from different faith backgrounds or individuals who are neurodivergent? There's all these demographics that we can focus on, but the key is we have to be better at it. Veterans is a really good example. We get asked a lot from clients to provide veterans marketing. Well, first and foremost, as a veteran, I'm pretty connected and plugged in most of the time. I'm talking to my military buddies, I'm talking to the VA, so I have a sense of where to go. And so I'm going to go to an established provider. So if you're opening a new veteran program, why would I choose the new veteran program that no one's ever heard of? But more importantly, again, the primary source of referrals with veterans is the VA. It's not individuals calling in, it's the VA. They make the majority of referrals, and most of the time they have to make the referral. Even if a veteran finds your program individually, they usually still have to go through the VA for paperwork and final referrals. So why is the VA going to refer to your program and not the other 3 programs it's been referring to in trusts for the past 10 years? You have to have something different. So the only way to do this right is to understand what your competition is doing, understand what they're not doing so well, and that what you can do significantly better, build that program, and then go to the VA and say, hey, look, here are the issues with your current referral partners, right? They're fine. You've been working with them a long time. We respect them, but there's a couple things that they could significantly improve on. We've done that. Here's how we built the program. Here's the staff we've hired. Here's the training that we do. Here's the outcomes that we're working towards. That is a viable message that would help us steal community, that would steal market share and community mind share from established incumbents. Finally, there can be a partnership focus, working with unions, working with tribes, working with healthcare boards, whether it's pharmacists or doctors or nurses. All of those require a lot of paperwork. There's usually a special focus that these organizations want. There's usually some kind of collaboration that they're looking for above and beyond a standard treatment program. So this is also an ability to create a differentiated program, is you're really good at working with unions, or you're really good at working with tribes. And that's both the clinical care model, it's the paperwork that you do, it's the relationships that you have with them. But again, for all of that, you have to have expertise, right? You can't just randomly say, well, we want to do this, or go do this and do this better. As the sponsor, do you really have a clear vision and a clear thesis of what a differentiated model for quality, for demographic focus, for partnership focus is, and a roadmap that someone else can implement? Because a lot of the time there isn't an existing model or experience within the existing leadership team at the provider that is going to be able to implement that on their own. You really need to have some clear guidance and a clear roadmap for them to be successful. If you have that, then a differentiated care model can be the way to go. In my experience, I haven't seen a lot of private equity that really has a clear grasp of what these care models are or what differentiated care looks like. If I said, hey, what's a good group session look like? Or what's a good individual counseling session look like? Or how can you compare bad cognitive behavioral therapy to good cognitive behavioral therapy? Most private equity partners don't know the answers to those questions. If that's the case for you, then this is generally not a viable thesis that you want to be working under. For most private equity, I would strongly recommend the workable thesis number 2, which is the extension of the local care model and the extension of the payer contracts and the differentiated operating cost models that you might have under those different contracts. So that's a wrap. As I mentioned, there's a lot of dead bodies in this space. A lot of people have been very unsuccessful in terms of growing, acquiring, or scaling programs. And it's really for the 3 primary reasons that I outlined in the beginning. It just wasn't a workable thesis. And then as we see within the workable theses, oftentimes providers and private equity sponsors don't have the really in-depth clinical expertise, the behavioral health expertise to deal with workarounds, to really build differentiated care models that are going to steal mind share and they're going to steal market share from incumbents. And so your best thesis is going with that local extension in terms of levels of care and payer contracts. If you have questions or if you ever want to work through some of these models, I'm available at the information on the screen. Appreciate your time.